Hello. My name is Jones, and today we are going to look at a case study in Mania. So, in our case study, we have PB or Patrick Bryan, a 25-year-old non-manic patient who has been admitted with history of impulsive behavior. He picked up an argument with his boss at work and hit him without warning. During admission, he was verbally aggressive and threatened to beat the nurses. So within this case study, we seek to answer the following questions. We're going to differentiate between bipolar 1 and bipolar 2. We seek to differentiate or to state the signs and symptoms of mania. We seek to mention the causes of mania. We seek to outline the risk factors to mania. We also try to endeavor to discuss the management of the client and the study within this case. And also try to explain the information, education, and communication that we are going to give to our patient on discharge. So we are looking at a case study in Mania, where a 25-year-old manic patient has been admitted with a history of impulsive behavior. This came into light after the patient picked up an argument with his boss at work and hit him without warning. So let us now define mania. Mania is a psychotic disorder that is characterized by an elevated, expansive, or irritable mood. Of course, there is also psychomotor acceleration, which is seen in mania. So mania is best appreciated in its definition by mentioning the characteristic of elevated, expansive, or irritable mood. So we also seek to understand the two types of mania, that is bipolar 1 and bipolar 2. We want to differentiate between bipolar 1 and bipolar 2. So let us look at bipolar 1. In bipolar 1, here the patient has had at least one manic episode. Please, in a bipolar 1, at least there's been one manic episode. Other things we see in bipolar 1 is that people with this bipolar 1 have full-blown mania, or they have hypermania. So bipolar 1 is also a kind of mania that puts people into the hospital for monitoring purposes. And people with bipolar 1 can start from hypomania, then move on to full-blown mania, or move on to hypermania. So bipolar 1, the client has had an episode of mania, and apart from that, he a patient with bipolar 1 has full-blown mania or hypermania, and it starts from hypomania to hypermania. Then let us now look at bipolar 2. A patient with bipolar 2 has never had a manic episode. Please, with bipolar 1, we said the patient has had, whilst in bipolar 2, patient has had not. So patient has had not had an attack of manic episode. So in bipolar 2, we are saying the patient has had not an episode, had an episode of mania. The things we see in bipolar 2 is that people with this have hypomania, and also other thing that we see in bipolar 2 is that it is a milder form of mania that can cause significant impairment in judgment, but it never goes over the top as it can with a full-blown mania, which is seen in bipolar 1. Okay, so let us now look at some of the signs and symptoms of mania. So mania presents with the following clinical signs, that is elevation of mood or increased irritability. In the definition, we talked about characteristic elevated moods. Okay, so elevated mood is one of these clinical presentation of mania. One cardinal and important, more like a blueprint of mania, is that of inflated self-regard. Okay, and the fancy psychiatry name there is a grandiosity. Patient has grandiose ideas, so they have inflated self-regard. And then the other signs and symptoms is increased energy and activity. So patients with mania, remember we said there can be psychomotor acceleration. So here they have increased energy and activity. Okay, then they also have increased talkativeness. Okay, here we're looking at a pressure over speech. Patients would want to be talking all the time. Okay, so pressure over speech. They have increased talkativeness. Then there will be flight over ideas. There can be decreased need for sleep, as patients with mania tend to suffer from insomnia. Then there can be decreased attention. There can be loss of inhibition. And apart from loss of inhibition, we can see other critical signs of mania, okay, which is delusion and hallucination. Okay, so apart from grandiosity, in mania we see delusion and hallucination. So when we talk of these psychotic symptoms in mania, that is delusion and hallucination. For delusion, there can be grandiose delusions or persecutory delusions. And then for hallucination, there can be auditory hallucination. And this is the common type of hallucination that the patient may suffer from. And these hallucinations, they often reflect prevailing delusional or beliefs. Okay, so now let us talk about etiology of mania. There is actually no specific known cause of mania, but we have predisposing factors that are grouped as biopsychosocial in nature. So they are biopsychosocial in nature. So that is within these three framework or three elements that we can view the causes or the etiology of mania. Okay, so in short, what we are saying is we have biological factors that may predispose to mania. We have psychological factors that can predispose to mania, and we also have social factors that can predispose to mania. When you're talking about biological factors, two elements come into play. That is genetics and biochemical makeup of an individual. So when you talk about genetics here, we are saying mania and major depression are hereditary in nature. First degree relatives or children of people with these disorders are more likely to develop the mood disorder than people in the general population. And then the other biological aspect is that of biochemical makeup or biochemistry. Research has shown that people with depression have less of neurotransmitter serotonin, whilst those with mania have too much of serotonin and epinephrine. So this forms the biochemical linkage in the predisposition to mania. So people that are prone or may show some kind of depression and the likes, they have less of neurotransmitter serotonin. Okay, whilst those who might those that might show depression may have less serotonin, whilst those that may tend to have mania may have the opposite of this, that is increased serotonin in their body and epinephrine. Okay, so these are the items necessarily that can be seen within the biological factors. So from biological factors, we can now talk about psychological factors. Psychological factors, here we can say people experience depression because their thinking is disturbed. Early adverse childhood experiences buried in the subconscious may lead to depression. So such people need to go for psychotherapy so that they deal with these subconscious adverse experiences. So if not necessarily helped, these patients may tend to have mania or show some signs and symptoms of mania. Okay, then we have the social factors. Stressful life events, lack of social support, and environmental stress, and also poverty can predispose a person to mood disorders. Okay, social factors, we are looking just necessarily one, lacking support. Okay, we are looking at an environment that stresses someone, cognitively challenges this individual to an extent that they start showing some manifestation within their psychological well-being, which tend to be more of psychiatry symptoms. Okay, because of stress. Okay, so now management of mania. When we talk of management of a condition, we are necessarily looking at three elements: the investigations that can be done, the treatment that has to be given, and the nursing care. When you're looking at medical management of the patient in nursing, we are looking at the diagnosis, the treatment, and the nursing care. So when you talk of medical management here, we'll look at the investigation first. So diagnosis of patients with mania is necessarily based on the signs and symptoms. So for these patients in the investigation, we are going to do history taking, we will do physical exam, we will do mental state examination, we are also going to do blood for chemistry analysis, and we can also do an X-ray. Okay, so in the history, when we take history, it will review signs and symptoms such as elevation of mood or increased irritability. Okay, that is from the history here. Then from the physical exam, some of the things that can be reviewed are features of increased energy and activity, and also increased talkativeness or pressure of speech. Patients within a physical exam may also show flight of ideas or decreased attention on assessment. Okay, so this can necessarily be reviewed during a physical exam. Then the other investigation that can be done is that of mental state examination, which is going to review features of delusions, hallucinations, and illusions. Okay, so that is within the mental state examination. Then we can also take blood for chemistry analysis. This is necessary to rule out elevated levels of serotonin and epinephrine. We said someone with depression, they have low serotonin, whilst those with mania have high serotonin levels and epinephrine. So you can do an analysis, okay, of blood to rule out elevation in serotonin and epinephrine. We are also going to do a skull x-ray. This is to rule out any brain injuries. Okay, but since we said that the diagnosis of patients with mania necessarily we look at the signs and symptoms, so it's important we appreciate the signs and symptoms that we are necessarily likely to see for us to come up with the diagnosis of mania. So I'm going to give some signs and symptoms, okay, in the diagnosis of a patient with mania, and within these signs and symptoms, we need to see at least 3 of them for us to make a conclusive judgment that the patient has mania. We need to see 3 from the ones that I'm going to talk about, which are signs and symptoms within mania. So we have inflated self-esteem or grandiosity. So grandiosity as one of the signs and symptoms that you can see. Decreased need for sleep, which is insomnia. So you might see a patient may have insomnia. Apart from grandiosity, they might show insomnia. They may also have pressure of speech or increased talkativeness. So if they have any of these or the 3 that I've just mentioned, then you can conclude the condition as mania. But otherwise, there are also other 3 that I would add. Okay, that is a flight of ideas can also be seen in mania, in case you don't see any one of the 3 that I've just mentioned. So we can see flight of ideas. Then we can also see increased goal-directed activity or psychomotor agitation. Okay, so this psychomotor agitation is seen in patients because of the psychomotor acceleration, okay, and increased flight of ideas or flight of ideas. Okay, then the 6th sign and symptom that can be seen is that of excessive involvement in pleasurable activities that have a high potential of painful consequences. Okay, so these 6 signs and symptoms, if patient shows 3 of them, 3 amongst the ones I've just mentioned now, then we can say the patient has mania. So we can make diagnosis based on the signs and symptoms. Then treatments for patients with mania, we are going to use the LH mnemonic here, that is the Lagactil, okay, and L is also for lithium. Then H is for haloperidol. So we give LH to patient with mania. So LH, that's just for L for 2 drugs, lithium and Lagactil. The other name for Lagactil is chlorpromazine. Okay, so you can give a chlorpromazine. Okay, so you can also call it the CHL or LH if you want to remember it that way. So those are the three drugs that are used in the treatment management of a patient with mania. Okay, so like when you talk of chlorpromazine, it is available for adults, that is 30 to 75 milligrams per oral, and it is given in 2 to 4 divided doses and can be increased to about 20 or 50 milligrams twice weekly until the symptoms in the patient are controlled. For children, you can give per kg body weight, and that would be 0.55 milligrams per kg body weight. Okay, and then mechanism of action of Lagactil is that when one takes Lagactil or chlorpromazine, it exerts antipsychotic effects by postsynaptic blockage of central nervous system dopamine receptors, hence or thereby inhibiting dopamine mediated effects. Okay, so when it does that, then patient signs and symptoms subside. Otherwise, side effects of Lagactil is that it may bring about drowsiness, sedation, tachycardia. It also brings about nasal congestion, constipation, menstrual irregularities, or hypostatic hypotension. Okay, so it is cardinal for nurses, as we prescribe, or nurse patients, is that when they are taking drugs, we need to appreciate the nursing implication, okay, based on the side effects and caution that is attached to each and every drug. So when one is taking Lagactil, some of the nursing implication is that you need to obtain baseline blood pressure before starting the therapy, because patient is at risk of hypostatic hypotension. Then you can watch for orthostatic hypotension because the patient is at risk of this hypostatic hypotension. So you watch out for orthostatic hypotension. Okay, so nursing implication, we simply appreciate that with the side effects that the patient may have, we do not want them to be adverse in the sense that they become severe and difficult to handle. Okay, so in our LH, H is for haloperidol. Haloperidol, okay, can come in different doses. That is the doses for adults and the doses for children. And the mechanism of action is that it has a strong postsynaptic blockage of the central nervous system dopamine receptors, thereby inhibiting dopamine effects. Okay, just like when we talked about the action of Lagactil having antipsychotic effects on the postsynaptic junction, or bring about blockage, okay, in the postsynaptic area of the central nervous system, hence inhibiting dopamine mediated effect. So even for haloperidol, it has strong postsynaptic blockage of the central nervous system, affecting or inhibiting dopamine receptors, hence affecting dopamine effect. Okay, so that is the mechanism of action of haloperidol. Okay, so immediately I hear of the P parts, peridol on psychotic drug. There is this one class of side effects that we see, okay, in some antipsychotic drugs and most commonly we see in haloperidol, and that is extrapyramidal side effects. Okay, there can be what we call extrapyramidal side effect. I've recorded the lesson on extrapyramidal side effect. You can always refer to that and know what are some of those extrapyramidal side effects that a patient may have. Otherwise, apart from extrapyramidal symptoms that can be seen, patient may have drowsiness, sedation, tachycardia, headache, and a dry mouth. Based on the signs and symptoms and the effect of the drug, we can say in our nursing implication, we are going to warn our patient or client to avoid activities that require alertness and good psychomotor coordinating. Like if, let's say, patient is driving, because of the sedation, it may impair their driving judgment, and unfortunately they may have an accident. So we have to warn and caution a patient not necessarily to drive. Okay, the other nursing implication is to tell our patient to avoid alcohol as it worsens the drowsiness. Okay, and then we can also advise the patient to relieve a dry mouth by chewing sugarous gum in order to promote saliva formation within the mouth. Okay, so when the manic behaviors have gone, long-term treatment is then focused on prophylaxis, okay, and stabilizing of patients. But otherwise, the lithium also is given with another, which has got another dose of about 300 milligrams, given 3 times a day. Okay, the side effects that can be seen with lithium include nausea, tremors, polyuria, and thirst, and then you can also have weight gain, loose stools, and cognitive impairment. So, looking at some of these side effects and others necessarily that we have not put here, our nursing implication is that for patients with renal impairment or thyroid disorder, we need to monitor serum lithium levels. Okay, that is 2 to 3 months in the first 6 months of the treatment, and then after 6 to 12 months thereafter, or more frequently if the clinical status of the patient changes. But otherwise, a patient who is on lithium requires that you analyze serum lithium 2 to 3 months within the period that the patient is taking the drug. Okay, so how are we going to nurse this patient? Okay, so nursing requires analysis, okay, of the signs and symptoms that the patient has. So when you analyze the signs and symptoms that the patient has, then you can identify the problems and the nursing diagnosis. So here, some of the identified problems or nursing diagnosis is that the patient may have risk of injury, that is to self or others. There can be risk of violence, that is self-directed or directed at others. There can be altered nutrition, less than body requirements. There can be risk of exhaustion. There can be altered thought process. There can be sensory perceptual alteration. Okay, we can also see other problems like impaired social interaction and sleep pattern disturbance in mania. So these are some of the problems necessarily that we can have in this condition. So when we say risk for injury to self and others, this is related to extreme hyperactivity. Okay, we can also relate it to destructive behavior that is seen in the patient, or we can relate it to the anger that is directed at the environment, or we can look at it in the terms of increased agitation of the patient, among other things. Okay, so problem identified here is the risk of injury to self and others, which you have tried to relate to extreme hyperactivity. Okay, so this is necessarily also evidenced by hitting a head. A patient may be hitting the head, or a patient may be hitting his hands or foot against the wall. So if you see this, then you can see that there's risk of injury to self. Okay, if they are hitting their foot on the wall, anyone who comes on the way and the likes, the patient may end up having a fight with them. So that is necessarily the risk of injury also to others. Okay, so the evidence is that of the patient hitting his head or his foot that is on the wall. Then risk of violence or self-directed or directed at others. This can be related to manic excitement, okay, the disease process, or the suspiciousness or paranoid ideation that is in the condition. So there's risk for violence, okay, which can either be self-directed or directed at others. So this risk of violence may also be seen because, or we can relate it to hallucination. Okay, so someone with paranoid ideas or hallucination, you do not necessarily know what is happening in their head, okay, and if those things are negative, it may lead to some risk for violence. Okay, so the evidence here can be body language, it can be the clenching of fists and jaws, hyperactivity, pacing, repetition, or verbalization. These can be the evidence for risk of violence. Okay, so the other problem we mentioned was that of altered nutrition, less than body requirements. We can relate this to refusal or inability to sit still long enough to eat, or lack of appetite. So that is why these patients have altered nutrition, less than body requirement. The evidence here is that by patients not having time to eat, they will lose weight, or they may look pale because they are too active and too busy to sit and eat something. Then the risk for exhaustion, this can be related to hyperactivity, pacing, and repetition of verbalization. So that is how you can relate it as you are qualifying your problems to a nursing diagnosis. And then the evidence is that we can see that the patient may be extremely fatigued because of hyperactivity. So patient becomes extremely fatigued. Then on auto thought process, we can relate this problem to heredity factors and the disease process. Okay, so altered thought process here, we can just relate it to heredity factor or the disease process itself. Okay, the evidence is here is that of D, delusions, H, hallucination, I, illusion. You can add more, but otherwise the evidence of auto thought process is that someone is having delusions, someone is having hallucination. So that is a sign that this person has auto thought process. Then sensory perceptual alteration, this can be related to hereditary factors or biochemical imbalance that is evidenced by hallucination, talking and laughing to self, or listening pause. Okay, so sensory perceptual alteration. Here, our patient, we are saying there is biochemical imbalance, okay, which is evidenced by hallucination. Okay, so it's quite tricky sometimes to compose an nursing diagnosis in the mental health. So I just felt I needed to put in something here so that you can necessarily use these problems, qualify them to be nursing diagnosis, okay, and you can now categorize them whether they are potential or actual, okay, and when something is potential, it's not necessarily that it has happened. It has not happened, but there's increased likelihood that it can happen. And then when you say it's actual, the problem necessarily exists. Okay, so how can we manage a patient with mania? Firstly, admit the patient. When we are talking of bipolar 1, admit the patient. Then you need to create a rapport with the patient or create a patient-nurse relationship. This is a therapeutic relationship to help the patient recover. Then you need to maintain a safe environment because of risk of violence that necessarily the patient poses because of delusions and hallucinations that they may have. Here it is important that the patient rests and you promote sleep because patient is at risk of insomnia. Because of inadequate time for them to sit and concentrate and eat, is likelihood of them having poor nutrition. So you might need to do something about patient's nutrition, manipulate the environment so that they can eat well. Then the patient needs to be given some social interaction skills within the cognitive behavior therapy so that the patient necessarily can recover. It is only after you have done this that's when you can give the information, education, and communication about the condition. Okay, so in managing a patient with mania, to do with admission, you should admit the patient, okay, to a closed ward in a psychiatry hospital or annex, as the patient possesses a risk of harm to himself, okay, by his psychomotor acceleration and expansive concept of himself. He should explain to his relatives the reasons of admitting him in a closed ward, as his delusions thought that he is having may be very strong, okay, like being a Superman, and this may lead him to perform dangerous feats such as jumping from a three-story building, okay, and or walking in fast-moving traffic without giving way to the vehicles. So this necessarily may happen with the patient with mania. So we are admitting to protect them and also protect others within the community. Should also explain to the patient that he poses a danger to others due to his persecutory delusions or hallucinations, as he might end up injuring someone, okay, as he acts upon these psychotic symptoms. Okay, so On admission, necessarily, this is very, very important to explain to the relatives, to explain to the patient, so that you can gain a cooperation. Okay, apart from that, we are saying create a nurse-patient relationship. Okay, it's important that you create a nurse-patient relationship so as to reduce suspicion and build trust in the patient, which will in turn make it possible to carry out collaborative nursing intervention. Explain every procedure that is done on the patient using your nurse-patient built relationship, as it also helps in gaining cooperation. Use a low tone when interacting with or talking to the patient. This is to avoid argument, since the patient may tend to be irritable. You can maintain a calm attitude when carrying out the nursing care. This is to avoid stimulating or worsening the perceptual errors that the patient may have. Please, you need to use clear and concise directions and comments, and keep your remarks brief, okay, or simple, because the patient tends to be hyperactive and has no time for lengthy discussions. Okay, patient's delusions or hallucinations may preoccupy him for you to start giving them long stories. So this is very important in creating a nurse-patient relationship. Okay, so how then can you maintain a safe environment for a patient with mania? Kindly observe the patient closely to do a risk assessment. Assess whether patient is a danger to himself as well as to others or staff. And you can monitor to promote safety of the clients after a proper assessment. You can set boundaries of behavior that is not expected and the consequences during a group therapy. Okay, that is both positive and negative. This is going to modify behavior, bring about good result in behavior therapy. On manipulative and violent behaviors, okay, as talkative patients, they can be disruptive because of following a tendency that is manipulation of self-esteem of others, ability to find vulnerability of others, ability to shift responsibility to others. So patients, manipulation of self-esteem, this ability, okay, should be monitored. Okay, you have to ensure that this manipulative and violent kind of behavior, they are punished to protect vulnerable clients and keep them from being drawn into anger that manic patient feels. Okay, so individuals, staff, and patients here, okay, that are working with the patient, you can try necessarily to limit the responsibility of people that may not understand the condition well. Okay, that may not understand the condition well because they may inflate or worsen the situation. You can diffuse conflicts and clarify communication among staff to follow the same agreed upon consequences for forbidden behavior when dealing with the patient. This will help to maintain discipline and also limit undesirable behavior. Okay, patient could have a limit set in which he is informed that if he threatens other patients or staff with violence, then he'll be given time out in which he has to spend time alone in a room by himself. You have to reduce environmental stimuli such as noise from television, radio, or crowded rooms because patients with hyperactivity, talkativeness, and the likes, these it can worsen the patient's condition because it will keep them more active, and the patient will fail to rest. So the perceptual errors that the patient has are distractible, and patients tend to respond to all sort of environmental cues within them. So maintain a calm attitude to avoid worsening the situation, as patients with mania tend to be hostile and aggressive. Ensure that you have a strong show of strength by having enough well-trained staff on the units to handle and control the patient in case his behavior worsens. In case of violent behavior, you can start by talking to the patient in a calm and matter-of-fact way. Remind him of any limits that he has broken, and if he continues with violent behavior, you have no choice necessarily but to physically restrain this patient and put him in restraints or in seclusion room for an agreed period of time, and you can now administer drugs that will help the patient to be calm. You have to also ensure that necessary observation and the care that the patient needs is carried out to prevent complications whilst the patient is in seclusion or restraint. Because when they are in seclusion, we may forget about them and not necessarily provide food and the likes to the patient. So we have to ensure that the necessary care that the patient needs, despite them being in seclusion, the care should continue. Okay, so to do with rest and sleep and provide opportunities for rest, relaxation, and ventilation of impulsive feelings. This helps the patient to become calm and also reduce the risk of acting out. Use clear, concrete statements and avoid abstract general statements when talking to the patient to enable the patient to understand what is being said and thereby prevent worsening of hallucination and delusions. Keep the room free from noise, as this promotes rest and reduce worsening of perceptual errors that the patient may have, like auditory hallucinations. Okay, so nest the patient in a dim light room, as this promotes sleep, but the lighting should be enough for easy observation. You have to do your nursing care collectively to allow patients time to rest and also administer, if prescribed, drugs like Valium, 10 milligrams intravenous or IM, to help the patient to calm from hyperactive behavior. So through these ways, through these methods, you are now promoting rest and sleep. Okay, so pharmacologically we have talked about Valium, but there are many nursing interventions that can be done other than giving the drug. We have also said nutrition might be an issue for this patient. So provide nutrition. So here we say finger meals. These are easy to eat. That is on the run, because the patient is unable to sit or stay for long enough in one place to eat a meal. So, if you are worried the patient may have altered nutrition less than body requirement because of poor feeding and the likes, you can weigh patient daily to monitor his nutrition status. And if symptoms subside, you can provide small frequent meals to the patient, as this also helps to promote appetite, unlike giving them big share or lump. So you might start thinking the meal is still there, it is still there, and only eat a small part of the meal. And you also have to ensure that you save your meals attractively. Okay, when you serve your meals attractively, patient feels encouraged to take their meal. Then the other part in nursing a patient with mania is that of social interaction. Okay, the nurse needs to have social interaction skills in manipulating patient's environment so that they can recover. So, accompany the patient to group activities beginning with more structured, less threatening ones, and gradually incorporate them in more formal or spontaneous activities to increase patients' socializing skills. You can assist in personal hygiene of the patient also, and appropriate dressing or dressing up activity for the patient or grooming of the clients. This is in order for patients to start functioning independently on what is necessarily required, because patients may not have time to dress up or groom themselves nicely, so you can try to assist so that the best out of this can come out. Okay, so in mental health, we want the patients to have independence, as this can help preserve self-esteem. So each and everything that we try to do for the patient, we are seeking patient's cooperation, and we want the patient, after some time, as part of the discharge plan, to be able to do those things by themselves. Okay, so you can spend intervals of time each day with the client, engaging them in non-challenging interaction. Okay, this is to develop trust and to avoid upsetting the patient. You cannot start playing a game with the patient who has a mania, because they shouldn't lose. Okay, because of their grandiose ideas, they have hallucinations and the like. So involve them, they lose, it can be another problem. So ensure also that you praise the patient for reality-based perception. Okay, so reduction of cessation in aggressive behavior and appropriate social interaction, group interaction. Also, if patient improves within this during their period of manic experience or perceptual problems, then please remember to appreciate the patient or praise the patient. Okay, so if there are legitimate complaints, please try to diffuse the irritability that may develop due to a lack of trust. Okay, so it's not everyone that might approve of each and every step that you might be trying to help the patient. So ensure you give proper explanation as to why you have ended up doing certain things. Okay, so information, education, and communication for a patient here. We are saying the family needs to be explained to why they are cooperating them on a lot of things that are being done because it will help them to continue helping the client even after discharge. So IEC, or information education and communication, also involves teaching the patient about their diagnosis, the signs and symptoms, prognosis of the disease, the importance of drug adherence, the drug adherence to prevent relapse, and also the psychosocial support that is needed for the patient, so that when they are discharged, they are well received at home, as it also promotes healing. IEC also involves teaching relatives and communities, also neighbors, as it is a safe way of avoiding neighbors or community members from provoking our clients, so that they do not have a relapse. So IEC can be given. There you have it. Today we have been looking at Mania, case study and Mania. In our lesson, we endeavored to differentiate between bipolar 1 and 2. We endeavored to state signs and symptoms of mania, endeavored to mention causes of mania, also explained or outlined the risk factors for mania. We have also discussed the management of patients with mania. Then lastly, we talked about the information, education, and communication, that can be given to the clients that has got mania. In our definition of mania, we said it is a psychotic disorder. So mania is a psychotic disorder. And what are the characteristics of mania? It's elevated, expansive, or irritable mood. So that is necessarily what you can see. But it is also important that within the characteristic, you have to note that there can also be psychomotor acceleration. Then bipolar 1, we said this is a type of mania in which the patient has had one episode of mania, and patients tend to be to have hypermania. Of course, the condition starts from hypomania to hypermania. Then bipolar 2, patient has not had the episode of mania, so they tend to have hypomania. So bipolar 2 is necessarily a milder form of mania. Of course, we see significant impairment in judgment, but it never goes to full-blown like hypermania or bipolar 1. We looked at about 9 signs and symptoms, or 10 signs and symptoms of mania, which included elevated mood, grandiosity, flight of idea, pressure of speech, decreased attention, and the likes. And then the other signs and symptoms of mania, being a psychotic condition, is that there is delusion and hallucination. We looked at the causes of mania, and we came up with 3 categories of predisposition to mania. So we said the cause of mania might be idiopathic. So some predisposing factors are biological, they are psychological, or they are social. So collectively we said they are psychosocial in nature. That is the predisposing factors. So we went on to explain biological factors, psychological factors, and social factors. After that, then we looked at the management of mania. And in management, we looked at the LAH, that is the treatment that is given in Mania. LAH being the mnemonic for lithium, lagactio, and haloperidol. Haloperidol, one side effect that you need to remember is that it brings about extrapyramidal side effects. And then we went on to look at investigations. So investigations, mostly diagnosis can be made based on about 3 signs and symptoms from the list necessarily that we talked about. Okay, but otherwise you can do physical history, you can do a mental state examination to arrive at the diagnosis. Okay, so thank you very much from me. I'm saying keep studying.